Welcome. Today's video, we're going to showcase a case that was sent in, missing tooth number 30 and 31. And according to the notes that was sent in, the patient lost the bridge from 29 to 30 to 31, removed tooth number 31 in May of 2014, did socket preservation with Orograft, which is a bone material. Um, he planned the implant in site 30 and 31. 31 looks like it has enough bone. 30 looks like it would need some help. I had trouble finding the nerve canal below 30 and 31. Is number 30 a graft first and place implant or place and graft at the same time? Also, how do I handle the lack of attached gingiva in site number 30? So there are several different questions there. Let me address the nerve. And again, when we have patients with large medullary cavities like that, it becomes harder to find the nerve. And I'm not saying that I'm going to be right on this particular case, but one of the things I like to do is in the tangential view right here, there's a slider, and I like to go ahead and use that slider. And slowly I will slide around, and I'm starting to see what looks like would be the mandibular canal right here. So if we look, take a closer look right here, it looks like right there would be the mandibular canal, because typically the canal is going to be surrounded by uh, a, um, a layer of bone all the way around. So that looks to be the canal. The other thing I like to do in this mode here is in the tangential view is just look clearly for the canal. And again, this is a very difficult case to determine where the canal is. So in cases like this, what I will often do is I will actually use the adjacent teeth as my limitation, like so, for how long I'll make the implant. Again, that's assuming I can't find the nerve or go through some different steps to really closely look for the nerve. I will use my adjacent teeth as my extension. Now, there are times where, even using the adjacent teeth is not advisable, but very rarely will we find the nerve suddenly do things like this, especially if we took the tooth out and grafted it at that time. So I'm pretty comfortable and confident that the nerve typically will be in a relatively straight line. But again, the nerve is not something to be messed with. So hopefully that makes sense what I'm doing there. So again, in this particular case, my guess is that the nerve canal is right here and not right here as it's been drawn. So um, we can go with that as our information. Alternatively, we can go down, and there again, there looks to be the canal to me. So yeah, this one is definitely tough to locate the canal. On this one, I would definitely be using shorter implants, taking care not to risk hitting the canal. So that answers that there. So now let's go ahead and take a look at our implant plans. Site number 30 will definitely need some grafting. Um, as we can see from here, the implant is outside of the bone. Now in this particular plan, I would like to take it up a little bit. I just I don't like how close that is. I know that with guided surgery and things we can be pretty accurate. I just don't like risking it right there. So especially when we have the ability to go a little higher. And now when I'm doing some lateral grafting at the time of placement, I do plan the implant subcrustal just in case I do have some bone loss from the procedure itself. But based on something like this, I would probably I'd be pretty confident doing the implant at the time of surgery. So in other words, I would go, sorry, the grafting at the time of implant placement. I would go ahead and place the implant and go ahead and obviously reflect a full thickness flap, decorticate, graft. You would have to do a nice release here to get primary closure of that tissue and place a membrane. But I personally, my surgical experience, my comfort level would be comfortable with that. If you want the most predictable and the most time-tested results, this would be a situation where we do the grafting first and then come back and do the implant placement. So in just critiquing this plan, the other things that I do notice here are occlusal plane in this particular case It's up and down, and we want it to be straight up and down. So what I would do here is I would go ahead and tilt this implant a little bit. And what we're going to start seeing as we tilt the implant is our occlusal plane starts looking a little bit better. Go ahead and move the implant over to center it. Come over here, and now we're starting to see that our implant is a little bit better centered. Um, and now we're also more in line with our occlusal planes. And by seeing tooth number 30 here, what we're also able to see here is tooth number 31 is definitely angled to the apex is angled to the distal there. So again, I would also go ahead and angle this over here. Now, one thing you can do is go to the change implant button and go ahead and ask the software to parallel that to tooth number 30. And now we've got an implant that's parallel. And again, we're close to the distal here and looking at our axial view. So just go ahead and draw the implant and move it over. Draw the implant over and then bring it up to the bone level. And looks like you did a nice job here grafting. So, I would certainly be pretty comfortable with this plan as we see it there, just like so. So, again, my only concern here is on tooth number 30. I would be comfortable grafting that at the time of placement. It's not as predictable. It certainly does involve a little more finesse in the surgery, but it can certainly be done. And then the other thing to take into consideration here is your interproximal space between the implants. You want to make sure that you have at least 3 millimeters, and here we do. The implants are well centered. Our occlusal plane looks quite nice. So from here, I would be ready to go. So hopefully this has been helpful, and thank you very much, and sending your case in.